Alright. So today we're going to do chapter 2021, mobility. So by the end of this lecture, you'll be able to differentiate the action, side effects, adverse reaction, and nursing interventions for Parkinson's disease drugs. Explain the side effects and interventions and nursing care for patients taking drugs to treat multiple sclerosis and ALS. And we're going to compare the action, side effects, adverse reactions, and nursing interventions for skeletal muscle relaxants. So in chapter 20, we're going to omit Alzheimer's, which is pages 266 to 269. And in chapter 21, we're going to do muscle relaxants only, no spasmodics or anything like that. So what is Parkinson's is the progressive loss of dopamine. It's a very common degenerative CNS disease. Symptoms can include tremors, muscle rigidity, and things like that. So the dopamine will actually, it is for making you feel better, making you feel happy and good and like goal oriented, but it also works on your motor movements. So that's why they have the tremors and the muscle rigidity. So it's like the progressive loss is like the progressive you have increased spasticity, so you become more spastic. So it's also the degeneration and destruction of dopamine producing neurons. It affects a part of the brain that controls unconscious muscle movement. It also can affect the dopamine and acetylcholine in the corpus striatum, which affects your balance and posture, your muscle tone, and your involuntary movement, which is what these are. And also the absence of dopamine allows acetylcholine to be stimulated more. So the goals of treatment is to restore dopamine function, block acetylcholine, and avoid EPS. A lot of medications that restore dopamine are called dopaminergic drugs. And these are like levodopa, amantadine, bromocriptine. Levodopa is like the most popular one. They use it all the time. There are some combos we'll talk about in a minute though. So then we have ones that inhibit the breakdown of dopamine. So this is tocopherol and selegiline. So these two are important to know, like important side effects are mouth sores and they're hepatotoxic. So if I'm already having trouble swallowing and trouble chewing or trouble speaking, and now I have mouth sores, it's going to make my time worse. Okay, so just make sure that they know that it can cause mouth sores. And if they start showing those kinds of symptoms, we maybe talk to the doctor and get it changed, especially if I'm already having trouble eating. I'm not gonna want to eat if I have mouth sores. Okay. So then we have the active dopamine receptors and the dopamine agonists, and then the other ones cause dopamine to release from the nerve terminals. These work very similar to the dopaminergics, sorry. Okay, Requip, ropinirole, that is a super common drug. We use it a lot for restless leg, which is also can be a symptom of decreased dopamine. It just kind of helps relax that feeling, and like it says, it activates dopamine receptors. But they're similar to the levodopa side effects as well. So then we have our catechol o methyl transferase, or our COMT inhibitors. Okay, so they reduce the requirements for levodopa and carbidopa. They increase concentration of existing dopamine in the nerve terminals, and so it improves motor fluctuations. There is a combo with levodopa, carbidopa, and entacapone. So this is called Stalevo. We're going to talk about it on the next slide. Okay, so this combo drug is all three: levodopa, carbidopa, and entacapone. Okay, it's only PO. It's for the Parkinson's symptoms. Okay, so it doesn't like prevent Parkinson's. It doesn't treat, doesn't cure it or anything like that. But it helps with the tremors, the bradykinesia, the gait, shuffling gait, muscle rigidity. So it restores the neurotransmitter dopamine in the extrapyramidal areas. Adverse effects: uncontrolled and purposeless movements. So, and we still have spasticity. spasticity is not the same as uncontrolled movement. So now when I have to go, the spasticity has to deal with, I want to pick this up and I can't control and steady my hand. These are uncontrolled movements. So this is the extending of the fingers, the shrugging of the shoulders. There's no purpose for it. It just happens. It's just like it's just a side effect. Loss of appetite, nausea, vomiting, orthostatic hypotension. That's a big one. I see that a lot, especially with the elderly. They get the orthostatic hypotension from this. This you can also have psychosis. So you can have hallucinations and paranoid feelings. You can give clozapine if they're having these kinds of symptoms. And then signs of toxicity is the muscle twitching, like when you've had a twitch in your eye or a twitch in your cheek, or you've had a muscle twitch. Okay, so it's constant muscle twitching and spasmodic winking. So it's like continuous, can't stop winking. Okay. These are important, this because it shows toxicity and we need to reverse it. Okay, so we have to avoid Haldol, methylidopa, because these things already kind of work on your CNS, and we don't want to have further CNS suppression and things like that. We don't want to cause EPS or NMS syndromes either. Okay, we also want to avoid kava, and treatment overdose is supportive. So if I'm having muscle twitches or spasmodic winking, maybe I need some muscle relaxers, or if I'm having some psychosis, maybe I need the medications, the clonazepam. So also we can try gastric lavage, IV fluids, and then airway management, because as you know, if they're having trouble swallowing or chewing, if they're having any muscle weakness, especially or muscle tightness, rigidity, we definitely need to know, because that'll affect our airway. So contraindications, narrow angle glaucoma. If you have any kind of melanoma or suspicious lesions, we don't want to give it. And then any kind of psychosis. And if you've had psychosis from an MAOI, we don't want to do it. So these patients are probably going to need help to self-administer. They're going to have tremors. They're going to spill if you give them a cup, they're going to shake and spill them. So they may need help administering them. Abrupt withdrawal can cause worsening Parkinson's symptoms. Okay. So if, let's say I took this, I stopped it, I could have worsening tremors, worsening muscle rigidity and things like that. And you could even have NMS, the neuro malignant syndrome. Okay. So don't stop it abruptly. Dyskinesia requires a low dose. So this dyskinesia is just like it's not the same thing as bradykinesia. Bradykinesia is the slowing of movements. So you have trouble, chewing consistently. Dyskinesia is kind of like the tremors. It's just trouble with movement. So monitor for NMS, monitor their liver function, teach the patient about the wearing off period. So sometimes when they take this medication, as the peak and the onset happen, towards the end of it, you can have a wearing off. So the symptoms come back full force. They still take it as prescribed, but make sure that they know that can happen. The symptoms can come back pretty severe, but we want to make sure we tell the doctor when this happens, so that maybe they need to up their dose more often. Okay. We also want to teach the patients about that a high protein diet, excess acid, and iron salts will interfere with the effectiveness. Okay. So they need to have a low protein diet. No, not much acidity. So like no tomatoes, no citrus fruits, things like that. And then iron salts, because this can reduce the effectiveness, and then it's not going to work. And so what's the point? Also with the orthostatic hypotension, we want to make sure we tell them the normal things: rise slowly, change position slowly, make sure that we don't fall. Okay. So now we have anticholinergics. They use anticholinergics as the very first line of Parkinson's therapy. So the first thing we do is we try anticholinergics. It's usually when the only symptom is a tremor. So like very, very early, okay? Because it's not the big dogs. We don't have to bring them out yet. Let's try this. This going to help with your symptoms, and then we can move up to the dopaminergic drugs. Okay. They're not as effective as the dopaminergics because this is for early symptoms. So we're not having to we're not treating multiple symptoms. We're treating one or two. Okay. So the biggest one is benzotropine, and you probably remember this because it treats EPS. So it's POIVIM. It's a central acting cholinergic receptor blocker. They use it for Parkinson's symptoms, EPS, and tremors. Okay. Blocks cholinergic stimulation. Common side effects, the anticholinergic side effects, because that's what it is. Okay. So remember, anticholinergic is your fight or flight. Okay. So we're going to have dry mouth, constipation, because our digestive system is not worried right now about producing anything. It said, I got other stuff to do. Tachycardia, and even like high blood pressure, remember, because it wants to raise everything so you can get blood flowing to where you need it to go, and you can run away if you need to. Okay. So other symptoms that are not anticholinergics are this sedation, the drowsiness, dizziness. You can have restlessness, irritability, nervousness, and insomnia. And the biggest one is muscle weakness, because the drug can work too good. So now my tremors are not spastic. I am flaccid. Like my muscles are super weak. Okay. There are a lot of drugs that interact with benzotropine, but we have to remember what it treats. Okay. If it treats EPS, a lot of these medications cause EPS. So we're going to give them together if they're having EPS symptoms, but we don't want to give them unless that's happening. Okay. So a lot of these are your psych drugs and things like that we've talked about. So just know that the reasons you don't take them together is because it can reverse the intended effect of these medications. Okay. And we don't want to do that. So, no foods, interactions, but we do need to know that the antidote for anticholinergics is the pheostigmine. Okay, so the pheostigmine 1 to 2 milligrams sub-Q or IV will reverse anticholinergic intoxication. Okay, so it's a very important drug. We need to know what that is and when to use it. Okay, so narrow angle glaucoma, myasthenia gravis, blockage of the urinary tract. These are contraindications. We know that with a glaucoma for the anticholinergics because it causes that dry mouth and the drying of the secretions in your eyes too, so it can make it worse. The blockage of the urinary tract, because we're not worried about digestion or urinary function. So if we're having a blockage and we're going to make something not pee as much, it's a problem, right? Severe dry mouth, hernias, severe constipation, and an enlarged prostate or liver disease. So again, they may need help administering it. It can be taken in divided doses 2 to 4 times a day or all at bedtime. If muscle weakness occurs, they need to reduce the dose. So if it's working too good and now I'm like got way too much muscle weakness, I need to reduce the dose. It's too strong. Okay. So we definitely need to monitor ambulation. We need to monitor their muscle tone before they get up, even so that if they're having this muscle weakness, we know we need to lower it. Okay. It's working too good. We want to monitor their blood pressure, monitor their heart rate and their anticholinergic side effects. And we want to teach them about reporting signs of urinary hesitancy or urination. I'm sorry, retention. This is because especially for older people who, I feel like we see a lot of people that are older get Parkinson's because it's a progressive loss of dopamine. So it takes a while for it to show up. So if you have an older gentleman, especially, and they start to develop an enlarged prostate, they may show urinary hesitancy or retention, and they may be having the enlarged prostate. So we need to make sure that they know they need to call the doctor if this happens, because we don't want to make it worse. Okay. So now we're on to multiple sclerosis. Multiple sclerosis is a very odd disorder. It's nothing that is super pinpoint. Okay. Some people have crazy symptoms, some people have very mild symptoms. It's a very full range. There's no one person looks the same that has no two people look the same that have multiple sclerosis. So this is an inflammatory disorder that causes the damage to myelin in the brain and spinal cord. And if you remember from A&P, myelin is the myelin sheath. It's what protects the neurons. Okay. So if your nerves are not insulated, they're going to hurt. It's going to be painful. They may not work. Okay. So you're going to decrease the effectiveness of the electrical impulses. So you have weird symptoms. That's what I'm saying. No two people look the same because everyone's nerves and what they do, like which ones are affected, may not be the same ones that are affected me. Okay. Inflammation, and it could even be just build up of plaque on the myelin and sheaths. There's no known cause and there's no cure. So signs and symptoms: fatigue, heat sensitive, it's nerve problems, okay? So neuropathic pain, impaired cognitive. The disruptions in balance and coordination is like the first sign, okay? How many times when you go to the doctor, they ask, or you've asked these patients, how many times have you fallen in the last 3 months? Have you fallen in the last 6 months? If so, how many times? What happened? Did you trip over something, or was it just like a fall? Because a lot of times multiple sclerosis is like an increased falls in a very short period of time. Okay. Um, like I said, you can have visual impairment, sexual dysfunction, lots of your nerves control your body. You can have all kinds of crazy symptoms. So it's really hard to diagnose because it's got a very wide range of symptoms. So we use disease modifying drugs. So we want to either treat the relapsing, readmitting multiple sclerosis or secondary progressive multiple sclerosis. A couple examples are the interferons and the glatimer. I'm gonna get this right. Glatimer. Okay, so these reduce the symptoms and decrease lesions. So the interferons, I don't know if you remember this back from A&P, interferons are what are released from your body when you have an infection, and it's kind of just your body's way of saying, hey, there's something going on. And it helps fight the problem, and we need to like figure out what's going on and fix it. Okay, so these interferons are going to have unfavorable side effects like flu-like symptoms because that's kind of what they do. So if your body says, hey, there's an infection because of the interferons, that's why you get this flu-like symptoms. Okay, because that's pretty much what they do. You can have anxiety, discomfort at the injection site, and they are hepatotoxic. So if they're taking any other kind of chemotherapeutics or bone marrow suppressing drugs, you need to know because they can cause worsening liver failure, and we definitely don't want that. Okay, so now we're on the glutaramer. Okay, so this is a synthetic protein that stimulates myelin basic protein. So it's thought that it curbs the body's attack on the myelin, reduces the lesions. Okay, side effects: redness, pain, swelling, itching, and a lump at the injection site, flushing, chest pain, anxiety, and then muscle stiffness. Okay. These are other medications that help with MS. There is a long list of them, and they all work differently. The fingolimod reduces the number of circulating lymphocytes, which are part of the lymphocytes are when you have an infection, so it kind of helps protect the myelin sheaths from being attacked. Dimethylfuramate is thought to inhibit the immune process that causes the damage to the brain and spinal cord, thus protecting the myelin sheaths. Teriflunomide, it is used for RA, and it has careful monitoring because it can cause kidney and liver failure and bone marrow suppression. So these are very bad side effects, and we definitely want to monitor for infections because if your bone marrow is suppressed, you usually have an increased risk of getting an infection. And then the dalfamridine is a broad spectrum potassium channel blockade. And you think, what does that have to do with anything? It increases the nerve conduction. So that's what the potassiums, they do nerve conduction. So that increases nerve conduction and actually improves their ability to walk, and they can walk faster and they don't have that slow shuffling gait anymore. And then the last one is the mitoaxtrone. This one targets B and T cells, which we know are used for infections, and they fight like mast cells and things like that. So this helps slow the progression of multiple sclerosis. Important side effect for this one is it will turn your urine a blue-green color, which is definitely something you want to tell someone before they start peeing blue-green. Okay. All right, so now we are on to ALS, or Lou Gehrig's disease. It's a most common degenerative disease of the motor neurons. There is no known cause. It is the slow progression of muscle weakness, atrophy of muscles, weakness of muscles, same thing. Every muscle. It is not a targeted muscle. So your brain is a pretty large muscle. They say flex, that's your brain. Okay. So if my brain is slowly atrophying, I'm going to lose the ability to initiate and control voluntary movement, lose the ability to speak, lose the ability to eat, have difficulty swallowing, not be able to move, not be able to breathe on my own. Okay. It is slow weakness of all muscles, okay? So there's two drugs. Riluzole is can extend the survival by reducing levels of glutamate within the CNS, which which helps prevent the atrophy. You slow the atrophy down. Okay. There's two forms. So if you're having trouble swallowing, they can give you these other two forms. They're just called something different. Okay. So one's a thickened liquid and one's a dissolving tablet. So if I'm already having difficulty swallowing or chewing, I need to do this. The other one is the adarovone. This one slows the decline in daily functioning. So my decline of daily functioning, so my ability to do ADLs, this helps slow that, okay? So if I can do more ADLs on my own. It has very specific IV instructions that are in your drug cabinet. So they do like a 14-day straight and then 2 weeks off. And then after that first 14 days, they do a 10-day 2-week off and they just keep it going. Okay, so you don't have to do this. It's not a one-time only. It can be used multiple times. The most important side effects are bruising, headache, and then you could actually have difficulties with mobility. So like it could just not work, right? Okay, so now we're on to muscle spasms, which are kind of go along with all the things we talked about, the spasticity, the MS and the ALS, we're having muscle problems. Okay. So now we have tonic versus clonic spasms. Tonic spasms are the constant contraction and that lasts a long time. Clonic is like as a contraction and relaxation, like it's just contract and relax for a period of time. Okay. So how do we treat these? We can give them pain medicine because that is painful. Your muscles get tired after a while. We can give them anti-inflammatories so that can help decrease the inflammation associated with the excess use of the muscle, or we can give them muscle relaxers. So what is my role as the nurse when I'm giving any of these three meds? I want to make sure I do, of course, I do my good assessment, my health history, allergies, drug history, things like that. Most important is I want to do a baseline level of consciousness, especially if I'm giving the muscle relaxers or the analgesics, okay? So if something's going to affect my level of consciousness or my vital signs, I need to know what their baseline is. Assess for drowsiness and dizziness. Again, if someone's going to alter my level of consciousness, I need to know what it looked like before so I can assess for drowsiness after. We want to monitor their pain, location, duration, and precipitating factors. See if they're having any kind of withdrawal reactions, especially if you stop the medications. Muscle tone's important, range of motion, degree of the muscle spasm. How hard is it spasming? Is it a tonic? Is it clonic? Is it just a regular muscle spasm that you have from overuse? And then we want to look out for side effects. So the central acting skeletal muscles, relaxants. They're muscle relaxers. Easier way to say it. It's a muscle relaxer, okay? It treats local spasms from muscle injuries. It can depress CNS, okay, and alter your CNS and alter spinal reflexes, okay? Reduces pain, increases range of motion. There is a potential for sedation. Cyclobenzaprine or Flexeril. I'm not sure about this Amarex. I've never heard that. I've heard Flexeril before. But cyclobenzaprine is a very, very common skeletal muscle relaxant. It's for muscle spasms and inhibits upper motor neuron activity within the brain. Okay. Biggest side effect, drowsiness. Okay, if I'm inhibiting motor neuron activity in the brain, I'm inhibiting my brain from doing what it's supposed to do at some place, I can have drowsiness. Okay. Blurred vision, dizziness, dry mouth, rash, tachycardia. So it does have like an anticholinergic effect. So the dry mouth, the tachycardia, things like that. Also angioedema can happen, but it's very rare. Alcohol, phenothiazines, and other CNS depressants. Makes sense, right? If I don't want to depress my CNS further, if I'm already going to have drowsiness from the cyclobenzaprine. There's no food interactions, but the pheostigmine is the reversal agent for the anticholinergic overdose, okay? Once again, so pheostigmine. So we want to contraindicate with MIs, dysrhythmias, or cardiovascular disease, because if we're going to stimulate the anticholinergic or the fight or flight, we're going to have that high blood pressure and the tachycardia. We don't need this extra stuff. Okay, if we already have heart issues, we don't need anything extra. And the hypothyroidism. thyroidism. Okay, remember everything's down but your weight. So you're bradycardic. You can have like a decreased mood and a decreased level of consciousness already. So we don't need to have any kind of effect on that. It's not recommended for kids. And if you use it on the elderly, you have to have extreme caution because they have an increased risk of having bad reactions. They can have confusion, hallucinations, and even cardiac events. So definitely need to monitor these patients. It can take a maximum of 1 to 2 weeks for this to work. Okay. So if they're giving this muscle relaxer to a patient who is going to be on this a long time, we need to tell them. It's going to take 1 or 2 weeks for it to really work. Okay. If you have someone that's got a pulled muscle, you definitely need to tell them because that's going to be a 1 or 2 week therapy. They don't need to just stop it because they're feeling better. They may not even feel the best results unless they keep taking it. So we want to assess for anticholinergic effects, especially in the elderly, even serotonin syndrome and drowsiness. Teach them not to drive or operate machinery because of the drowsiness. Okay. If you're going to give this patient a Flexeril before they go home, they need to have a ride. They can't drive themselves. Avoid alcohol. Once again, take it with food, and increase fluids. Okay. Because it can have it can make you sick, but it also can increase absorption. Okay. And that is all of mobility. There's a lot of drugs, but not a lot of thought behind them, if that makes sense, because they're kind of all the same. So study. If you have any questions, post in the discussion board, email your questions if you have them. And good luck.